Hello and welcome. My name is Rahul Shivastu. In this video, we're going to work through atopic eczema in children under 12 based on NICE CG57 updated to September 2025. The aim is to make the guidance feel clinically usable, not just as a list of treatments, but as a way of thinking clearly about eczema in a day to day primary care, barrier dysfunction, inflammation, recurrent flares, family disruption, and the importance of getting the basics consistently right. One useful way to frame eczema from the outset it as is as a barrier disease with inflammatory consequences. That matters because once the skin barrier is compromised, water is lost more easily, the skin becomes dry and irritable, allergens and microbes penetrate more easily, and the inflammatory cascade becomes easier to sustain. So, although families often describe eczema as a coming and going, the biology underneath is often ongoing with visible flares sitting on top of persistently vulnerable skin barrier. And because flares can happen 2 to 3 times a month, the clinical burden comes not only from severe episodes but from repetition. That is often why good steady primary care makes such a difference. In a short consultation, it often helps to keep the encounter focused around three priorities: confirming the diagnosis, simplifying the treatment plan, and understanding what may be getting in the way of good control at home. The NICE framework is a very practical here. The condition is common, long term, and often disruptive to sleep and family life. At the same time, topical corticosteroid concerns are extremely common. So, one of the most valuable parts of the consultation is often the conversation around confidence, safety, and how to use treatment properly. A helpful question early in the consultation is, what has made treatment difficult so far? That often gives you the answer much faster than adding more products. The useful practical point here is that eczema remains in most cases a clinical diagnosis. So the consultation is really about pattern recognition, itch distribution, chronicity, dry skin, and atopic background. Once the pattern is clear, tests are rarely needed to prove eczema. It also helps to remember the age related pattern. In infants, cheek and extensor involvement may dominate before the classical flexural picture appears. That saves a lot of uncertainty in younger children who do not yet look like the textbook school age pattern. One subtle but important clinical point in that eczema can look quite different across skin tones. In darker skin, inflammation may show itself less through obvious erythema and more through lichenification, roughness, follicular prominence, hyperpigmentation, or hypopigmentation. Keeping in mind helps avoid underestimating severity. The history is also where you begin to understand the real shape of the problem. A very helpful mental checklist is onset, pattern, frequency of flares, previous treatments and response, possible irritants, dietary history, sleep disruption, and growth. That usually tells you whether you're dealing with mild eczema, undertreated eczema, infected eczema, or eczema that needs escalation. This slide is especially useful because it reminds us that severity is local as well as global. A child may have mild trunk disease but much more inflamed flexures or face. Treating each area according to its own severity is one of the quiet refinements that often improves results quite quickly. Another point worth keeping in mind is that lichenification tells you something about time. It usually means the skin has been inflamed and is scratched for long enough to thicken, so it often signals a need for a clear, clearer flare plan and sometimes more proactive maintenance strategies. This is one of the most important messages in the whole guideline. The skin severity and the life impact do not necessarily match. So, in practice, a brief but focused question about sleep can be incredibly informative. If the child is waking repeatedly, the whole family may be operating in a state of chronic fatigue, even when eczema does not look spectacular in the clinic. That is why NICE is right to separate physical severity from quality of life impact. It helps us make more human treatment decisions. Families are often very observant about possible triggers, and it is worth listening carefully to those observations. What helps clinically is sorting likely irritants from true allergic drivers. In practice, irritants such as soaps, detergents, fragrance products, and friction are often more consistently relevant. From a microbiology point of view, it also helps to remember that eczematous skin is commonly colonized with Staph aureus, and that colonization can amplify inflammation even before there is obvious bacterial infection. So, not every flare is purely allergic or purely irritant. Sometimes the biology is mixed. Food allergy deserves a more selective approach. NICE is careful here, especially in younger children with immediate reactions, gut symptoms, poor growth, or eczema that remains moderate to severe despite genuinely good treatment. That is the group in whom food allergy becomes more clinically meaningful. A helpful way to think about this slide is that the barrier strategy stays constant while the anti inflammatory intensity changes. Emollients remain in place at every stage because the barrier problem is always there. Then, depending on the severity, you add the right strength of anti inflammatory treatment and step up or down according to response. That framing often makes the treatment plan much easier for families to understand. The moisturizer is the long term background support. The steroid or other anti inflammatory treatment is the flare control. One of the most practical changes in eczema care is simply prescribing emollients in quantities that match how they are actually meant to be used. If the plan is a whole body application every day during flares and between flares, then the prescription needs to make that realistic. NICE's 250 to 500 grams weekly is a very helpful anchor. There is also a physiological reason emollients matter so much. They reduce transepidermal water loss, soften the stratum corneum, reduce itch by improving the barrier, and make flares less likely over time. And in real practice, acceptability matters. The best emollient is often the one the child and family will genuinely use consistently. A very practical pearl here is that eczema care often improves when we remove the wrong products, not just when we add new ones. Detergent based washes strip lipids from an already damaged barrier, so moving to emollient washing is not a cosmetic adjustment, it is part of restoring the barrier environment. The NICE update on bath additives is also useful because it simplifies advice. Families often assume elaborate bath products must be helping, but the evidence tells us the real value lies in leave on emollients and sensible cleansing, not in routine bath additives. And the 2025 clarification about bathing frequency is reassuring. There is no evidence based need to impose a rigid bathing schedule. Gentle, acceptable, sustainable routines are what matters most. A really helpful way to think about topical steroids is to match potency to the biology of the site. The face, neck, axilla, and the groin absorb more readily because the skin is thinner or more occluded, so lower potency or shorter duration is usually enough here. By contrast, inflamed trunk and limb eczema often needs a stronger anti inflammatory approach than families initially expect. This is also why good site specific instructions matter so much. It gives families confidence that the treatment is being used thoughtfully, not casually. And a very small but very useful practical point, labeling the potency class on the actual tube is far more helpful than relying on the box because the box is often long gone by the time the child next flares. One of the most valuable clinical conversations here is helping families understand the balance between disease burden and treatment risk. Rather than simply saying steroids are safe, it is often helps to explain what uncontrolled eczema does. Persistent inflammation, barrier failure, scratching, infection risk, poor sleep, and ongoing distress. Once that is clear, the role of appropriate steroid treatment makes much more sense. It also helps to explain that visible improvement often comes before inflammation has fully settled. That makes the next slide, the 48-hour rule, feel clinically logical rather than arbitrary. The physiology behind the 48-hour rule is worth explaining because it is easy for families to understand once they hear it. The visible redness may settle before the inflammatory process has fully resolved. So, if treatment stops the moment the skin looks better, residual inflammation can reestablish the flare quite quickly. Continuing for another 48 hours is often what properly extinguishes the episode. The same principle sits behind weekend therapy. In children with frequent relapses in same areas, proactive treatment on 2 consecutive days each week can interrupt the flare cycle before it fully reestablishes itself. This is a very practical prevention strategy, and families often find it empowering because it gives them a way to stay ahead of the eczema rather than always chasing it. A useful way to place calcineurin inhibitors is as a steroid sparing option in the right clinical context. They're not there because steroids are banned. They are there because some signs, especially the face and the neck, may need long term repeated anti inflammatory treatment, where steroid exposure becomes more difficult over time. So these agents are best thought of as selective tools, usually within a specialist supported plan, especially when repeated facial flares are becoming a pattern. And because they are immunomodulatory, it is particularly important not to use them on actively infected skin. A practical point where suspected bacterial infection is to look not only at the skin but at the change in behavior of the eczema. Sudden worsening, more exudate, new pain, crusting, treatment failure, or systemic upset are often the clues that matter most. Microbiologically, Staph aureus is the organism most often sitting in the background here, but it helps to remember that colonization and overt infection are not identical. That distinction partly explains why the management of infected eczema has become more nuanced over time. The advice about replacing opened topical product after infection is also very practical and easy to forget, but it makes good sense from an infection control point of view. This is one of the high priority diagnoses to keep clearly in mind because early recognition changes outcome. The clues are combination of rapidly worsening pain, clustered vesicles, punched out erosions, and sometimes a child who looks clearly unwell. The morphology matters here. The lesions often look more monomorphic and more viral than ordinary infected eczema. Once eczema herpeticum is suspected, management needs to be immediate and decisive. Systemic acyclovir, same day specialist advice, and ophthalmology if periocular involvement is present. This is one of those areas where a low threshold for action is appropriate. The most useful mechanistic point here is that eczema itch is not primarily histamine mediated. That is why antihistamines are often less helpful than families expect when given simply for itch. The more effective route is usually to improve the barrier and reduce the underlying inflammation. Where antihistamines can still be useful is in selected situations, urticaria to overlap, severe itch in the right context, or short term support with sleep during acute flares. That makes them targeted adjuncts rather than routine eczema treatment. Referral works best when used as a timely extension and of good primary care rather than only as a last resort. What NICE offers here is a very workable framework. Not only for severe skin but also for diagnostics and uncertainty, persistent poor control, facial disease, recurrent infection, suspected contact allergy, food allergy, concerns in moderate or severe disease, psychological burden, and growth issues. That is especially helpful because it reminds us that eczema severity is not only about visible surface area, the overall clinical picture matters. This is where excellent eczema care becomes sustainable. A short demonstration of quantities, order of application, flare recognition, infection signs, and when to stop treatment up can transform confidence at home. Often, a few minutes of clear teaching here saves repeated unscheduled consultations later. This is also where practical language helps. Specific, concrete instructions are far more useful than vague advice. Cultural tailoring matters when advice fits how the family actually bathes, cleanses, and looks after the child's skin. Adherence becomes much easier. What is helpful about these updates is that they simplify practice. The direction of travel from NICE is very clear. Keep the focus on what is evidence based and workable. Leave on emollients, correct anti inflammatory use, and clear education, and move away from traditional extras that sound attractive but do not have a good supporting evidence, such as routine bath additives, water softeners, or silk clothing. The guidance on bathing frequency is also useful because it allows us to be flexible and pragmatic rather than dogmatic. If I were distilling the whole guideline into a few practical habits for primary care, they would be these: assess both skin severity and life impact, keep emollients central as the background barrier strategy, use topical steroids confidently and site appropriately, treat flares early and for long enough, use weekend therapy thoughtfully in frequent relapses, and keep eczema herpeticum clearly on clinical radar. Those few habits go a long way. Thanks. Thanks very much for watching. I hope that this has made the NICE guidance feel a little more practical and a little easier to carry into everyday primary care. When eczema management is clear, confident, and consistent, the gains for the child and family can be enormous, not just in the skin, but in sleep, comfort, confidence, and family life as a whole. Thank you for watching. And if you like our videos, please subscribe that and visit a4medicine.co.uk for further educational resources. Thank you.